Welcome to Health Talks. I'm Laura Militana, the Communications Manager for Cookeville Regional Medical Center. Thank you for joining us today for Health Talks. And today we're going to be talking about strokes with Dr. Mark Tedford, who is our Stroke Center Director, and talking about prevention, what it means to be a stroke center, what signs are, things of that sort. So I'll let Dr. Tedford take it now.
Well, thank you.
Thank you.
How can I screen share here?
Here, go to share screen.
Okay.
And then that one. Then share. There you go.
All right. Is that visible?
Yes.
Okay, thank you. And I don't think I have more than an hour here. So please feel free to interrupt with questions. I know it can be a little clunky on these virtual meetings, but anyway, we will talk about stroke today. This is what I spend about half of my work as a neurohospitalist treating here in the hospital. So a brief agenda for what we'll try to cover today. We'll talk about what exactly a stroke is and how big and bad the problem is and how common stroke is. We'll spend the majority of the time talking about how to prevent stroke, and then a little bit at the end about how to recognize symptoms and what to do when you might identify that you or someone else is having a stroke. So broadly speaking, stroke is when the brain becomes dysfunctional and then dies because of a lack of blood flow. And so that can happen really in two main camps. The images on the left, the one at the bottom, just a cartoon, the one at the right, the one at the top, a CAT scan, shows the difference between ischemic strokes, which are the great majority of strokes. That's when there's an obstruction of blood flow in a blood vessel supplying a part of the brain, or a clot that blocks off or occludes a blood vessel supplying part of the brain. And when that happens, all the brain tissue that's supplied by that blood vessel will be starved of oxygen and will, over time being minutes to hours, die. And sometimes we can reverse that. Sometimes the clot will spontaneously resolve or be dissolved before there's much permanent damage. And then on the right, again, the cartoon and the CT scan as well, that bright stuff on the CAT scan is blood. And so a hemorrhagic stroke or a wet stroke occurs when that a blood vessel ruptures. And so it's like if you're watering your garden and your hose springs a leak, the garden isn't getting as much water anymore. And that same sort of thing. And that chunk of brain becomes dysfunctional. And if the starvation of blood lasts long enough, it will die. Now, these two CAT scans, they both affect the same side of the brain. If when these patients first develop symptoms at home or when they get to the hospital, it might be impossible to distinguish which kind of stroke is happening until you get a CAT scan. And that's part of the reason why we try to get CAT scans. In general, when a person comes to the emergency department, we'll try to have them in the scanner within about 10 minutes, because everything we do depends on identifying what type of issue is going on. This is just a cartoon that always amazes me. It's called the homunculus. It shows the organization of the brain. This is just purely because it amazes me. So when a patient has a stroke, the puzzle I'm always trying to figure out is what part of the brain is affected. And so this shows that if you slice the brain in half this way, it's very precise what part of the brain represents, say, the foot. So a stroke there will cause just foot weakness or numbness. A stroke here, just knee. A stroke over here, just the top of the head. And so it's amazing how eloquent the brain is, and how inscrutable its detail is. So how bad's the problem? Well, in the United States, we have about 800 strokes per year. Many of them are silent strokes, or strokes that the person might not even realize they've had. But someone dies about every 3.5 minutes from a stroke. This purple map is pretty famous in the world of stroke. This is put out by the CDC every couple of years. It shows the frequency of death due to stroke broken down into every county in the United States. And you see all the dark purple in the Southeast, and that's us. And that we're number 4 refers to Tennessee being number 4 in terms of stroke death by state. So it's not exactly a claim to fame. It is worth noting that we're getting better nationally in terms of stroke death rate. So this blue line traces about 110 years from 1900 to I think about 2010. And you see that the rate, this is an age-adjusted death rate, so it's a little technical, but the rate of death due to stroke has pretty steadily declined over the last century. You see that over the last half century, the rate of heart disease has also declined. It's not on the graph, but you would see the rate of malignancy or cancer deaths increasing if that were on this chart. That has largely taken the place of a lot of these vascular deaths. And this is just to show that stroke is now the 5th leading cause of death in the United States. And so for the longest time, it was number 4. There was a bit of rejoicing in the stroke world when we got it down to number 5. But it's still one of the top 5 leading causes of death. And even more frequent, one of the major causes of disability. I think the estimate is somewhere in the neighborhood of $50 billion a year in direct and indirect, financial burden due to stroke. And just to put it a little closer to home in historical context, Israel Putnam, the namesake of Putnam County, made his daring escape from the British in February 1779, and later that year had the stroke that ended his military career. And Richard Cook, the namesake of Cookeville, died of his stroke just a few miles from here. So moving into where I hope to spend the majority of our time, what I spend a lot of my time working on with patients is how to prevent the next stroke. Usually I don't see patients until the first one, unfortunately. And so when we think about the risk factors of stroke, we try to break them down into 2 major camps: those that we can't fix, the non-modifiable risk factors, and then the ones that we spend most of our time on, the modifiable risk factors, or the things that we could make better. And so your risk of stroke goes up as you age. And that's just in the same way that hearing and vision and smell and memory and all these things decline as we age. The blood vessels in our heart and our brain become more brittle as we age, and so the risk of stroke goes up. You might be able to, like Tom Brady, slow that down somewhat, but the aging still happens. Similarly, whites have about half the risk of stroke as Blacks and Latinos. So some of that's likely genetic. Some of that might be differences in diet or access to healthcare or things like that. And then men are less healthy than women in so many ways, and frequency of stroke is yet another. But again, where I spend the majority of my time with patients is thinking about modifiable risk factors, the things that we might be able to make better. So the general consensus is that about 80% of strokes would be preventable if we all lived optimally healthy lives, if we all exercised and ate as we should and controlled our blood pressure and our diabetes and all that sort of stuff. Roughly 4 in 5 strokes, it's thought, could be prevented. And so I'll sometimes ask patients who have high blood pressure and high cholesterol and diabetes and smoking, what do you think is the most important of these? And the data is actually pretty clear. Most people will guess smoking, but control of blood pressure is where the greatest gain can be made in limiting stroke risk. This is from an American Heart Association article from a little over a year ago. And so just for your reference, this is the American Heart Association's breakdown of normal blood pressure versus varying degrees of high blood pressure. And, I think we in medicine, certainly I'll confess as myself, when I see so many patients with a systolic blood pressure, the top number at 200 or 220 or 180, that when I see somebody with a systolic blood pressure of say 160, it doesn't seem all that bad to me. And I have to remind myself, no, that's stage 2 hypertension. That's a big deal. Well, how big a deal is it? This is, this study compared to most others exaggerated it a little bit. But if you look at the graph on the left here, a person with a systolic blood pressure of, I think that's about 127. If that's our reference, they have a relative risk of 1 of having a stroke. If their blood pressure is about 15 points lower, their stroke risk has dropped in half. If their blood pressure goes up another 15 points or so, their stroke risk has more than doubled. It's now 2.5 or so. And that person with a systolic blood pressure of 165 is up around 16 times the risk of stroke. Now, the general consensus or teaching is that every 20-point increase in systolic blood pressure doubles stroke risk. And that's cumulative. So 180 is 4 times worse than 120, for instance. But regardless of the precise rate at which stroke risk declines with better blood pressure control, it's really significant. And especially someone with a blood pressure at 180 or 200, they're just at a massively increased risk of stroke. It's really hard on the blood vessels over many years. So what do we do about hypertension or high blood pressure? Well, of course, the easy answer is medication. And there are just so many. It's almost limitless now, the number of drugs that can have some effect on hypertension. In general, the thought or the goal when you start a blood pressure medication on a patient is that you'll get about a 10-point reduction in the systolic blood pressure. And so, someone whose blood pressure is at 180 is going to need a whole lot more than 1 or probably even 2 medications to get down to a reasonable goal. Well, what else will get someone's blood pressure down? Because I've yet to meet a patient who's like eager about adding another medication, side effects and the hassle and the cost. So 150 minutes of walking per week, so that is 30 minutes per day, 5 days per week, has about the same effect on lowering blood pressure as taking 1 blood pressure medication. If your exercise is more vigorous, say running instead of walking, you can cut that required time in half to get the same effect. So that has 0 side effects, and aside from some walking shoes, 0 associated cost, and has all kinds of other beneficial effects on mental state and depression and sleep quality and memory and all that. So that's low-hanging fruit when somebody wishes to avoid medication. And we'll talk about this a bit more a little later, but sleep apnea is super common. It's estimated that more than half of patients and perhaps 2/3 who have stroke will have sleep apnea. So this is, just in brief review, a condition in which people, their breathing is obstructed or occluded in the throat as they're sleeping. And so though they may not wake up all night, their body feels like it's being strangled and releases steroids and all sorts of things as part of the sort of fight or flight response without even waking up. And that over months and years just makes blood pressure really difficult to control. We'll talk more about that in just a bit. And then having a healthy body weight, this probably goes along with exercise, but you see as body mass index increases, resting systolic blood pressure increases. Now, how much weight do you have to lose to get that same sort of 10-point benefit in blood pressure? It's probably 35 or 40 pounds for most people. So that is not easy for most, but it is another potential way to drop blood pressure. So after high blood pressure, which affects most of my patients, I would say, who've had a stroke, smoking is less common, but also a very big deal. The question, of course, is how big a deal? So how would you quantify the effect that smoking has on risk of stroke? Well, for 1 pack per day or 20 cigarettes per day, it increases stroke risk about 6-fold versus someone who doesn't smoke. So to my eye, that's pretty dramatic. And often I'll see somebody after their second stroke or their second hospital admission after a stroke. And I'll ask if they smoke, and they say, yeah, but I've cut way down. I was smoking 2 packs a day. Now I'm down to 4 cigarettes a day or something. So how much benefit is there in cutting down smoking? It's thought that going from a pack per day, 20 cigarettes per day, down to 1 cigarette per day, so cutting out 95% of cigarette use, only reduces your stroke benefit by about half. So it's better than nothing. But even a cigarette a day is really harmful as it pertains to stroke risk. So abstinence is the best medicine here. The other objection I often get when talking to people who smoke and have had strokes is, yeah, but doc, I've been smoking since I was 14. I'm 60 now. Like surely the damage has been done, and I kind of enjoy it, and it makes me feel better. So I'm just going to keep doing it. So this is not specific to stroke, but just to show time intervals after someone quits smoking and various benefits of their body. So if you look down to the 5-year mark, third from the bottom, your risk of stroke returns to that of a non-smoker. So it takes a long time, 5 years, to sort of undo the effects of tobacco. But even at 6 months or 1 year, you're starting to get pretty significant benefit when it comes to stroke risk. So I'm always trying to help patients overcome these sort of mental blocks. I think the last study I saw said most people will try between 8 and 11 times to quit smoking before they're successful. And so, I'm never down on people who have tried and been unsuccessful. I just hope that the next time will be the one where they find success. After smoking, one that's a little harder to quantify is diabetes. So chronically high blood sugars cause blood vessels essentially to become more brittle and cause plaque to build up more quickly. And that's shown in this cartoon here. The effect of diabetes is really cumulative over time. So it's thought that the risk of stroke increases by about 3% per year for every year you've had diabetes. And that's variable based on how severe or how poorly controlled the diabetes is. And this is additive. So after 15 years, you're at 1.5 times the normal risk. After maybe 25 years, you're at 2 times the risk. Again, highly dependent on how severe the diabetes is, how well controlled. There is evidence that controlling blood sugar in someone even who's had diabetes for a long time, that it is beneficial in lowering stroke risk. It's somewhat debated how significant that benefit is. Next, I think we have 3 more, is high cholesterol. In this one, there's a little bit of a paradox here in that people who have high cholesterol and are placed on statins or cholesterol medicines have lower risk of stroke. So you see that in the top graph on the right. Rosuvastatin is one of the more potent statins. And you see that over 5 years, it reduces stroke risk by almost half. That's in patients with certain risk factors. Low cholesterol and taking statins increases risk of a bleeding stroke somewhat. So there is net benefit in taking statins because the risk of ischemic stroke or a dry stroke is higher than the risk of a bleeding stroke. So anyway, most of our stroke patients before they leave the hospital will be started on a statin. And that is really regardless of the number of their total or bad cholesterol. That's based on recommendations from the powers that be in the American Heart Association. So I talked, frankly, a bit more than I intended to about sleep apnea. This cartoon might have been helpful a minute ago in showing that the airway can be blocked off at night. There's a pretty high genetic predisposition depending on how your jaw and tongue are just built in you. But the risk for sleep apnea also goes up dramatically with increased body weight. And the treatment for this are these CPAP machines in the bottom picture. They used to, the old style sort of covered the nose and the mouth, and a lot of people said they made them feel like they were suffocating. This is a newer version. The newest are micro CPAPs that just like clip into the nose. But I was on vacation with my mom several years ago and could hear her in the next room stopping breathing all night. And the next morning I said, Mom, you have terrible sleep apnea. We need to get you a sleep study. You know, talked about all the reasons this was harmful for her health. And she said, yeah, I know, but I don't want to do those machines. I mean, they just look awful. And she loves her. She feels so much better all day with her sleep apnea being treated. So if you're concerned about sleep apnea, but you're put off by the mask, I'd say at least give it a trial. So, of course, it depends on how severe the sleep apnea is, but in general, it's thought to increase stroke risk a few-fold. It's hard to tease out sleep apnea on its own. You know, it is associated with obesity, for instance, and that increases stroke risk on its own. But in one fairly recent study that I thought was fascinating, this is not related to reducing stroke risk, but patients who had a stroke, who had sleep apnea, and were given a CPAP after their stroke, they actually recovered better. They had less disability and presumably also lower risk of a second stroke. So this is one of the screening questions that most of my patients will get after they've had a stroke is symptoms suggestive of sleep apnea. And what are those symptoms? Well, this is the Epworth Sleepiness Scale. This is the generally accepted test to rule out sleep apnea or to rule in the possibility of it. So for each one of these rows, the question is, how likely are you to nod off if you are sitting and reading or watching TV? And basically, the more likely you are to nod off during the day, the more likely it is that you're getting poor quality sleep at night. And so the higher your odds of having sleep apnea. So if you have a sufficiently high score on a screening tool like this, the recommendation would be a sleep study where your breathing is measured all night to see if you're having episodes of apnea or not breathing. All right, I think the last of our modifiable risk factors is atrial fibrillation. So this is an abnormal heart rhythm. So normally there are a clump of cells in the heart that function as a sort of pacemaker. So they're the ones that dictate, you know, if your heart rate is 60 or 70 beats per minute. And generally, well, if you see on the left EKG strip here, generally this little bump is when the atria, these top chambers of the heart, contract all together. And then this very sharp high spike is when the ventricles, which are bigger and have more muscle, contract. And so that would be a normal strip. This one on the right, where you just have kind of squiggles and then a big ventricular contraction, that shows that the atria, the top chambers, aren't contracting all together. They're fibrillating or just sort of muscle cells contracting at random. When that happens, there's a risk of developing clots within the atria, those top chambers of the heart, which can then get loose and travel to the brain and cause a stroke. It can also travel almost anywhere else in the body. It's just if a clot goes to your liver, you're unlikely to even realize it. If it goes to your brain, we have very big issues. So atrial fibrillation, again, like everything else, it depends if you're consistently in AFib, or some people will have it for 5 minutes and then not again for 2 months. But it increases stroke risk dramatically. The treatment classically was a blood thinner that I think almost everyone's heard of, called warfarin or Coumadin. And that is thought to reduce the risk of stroke by about 2/3 in people who have AFib. Excuse me. Some of the newer agents, you might have heard of Eliquis or Pradaxa, Xarelto. Those are about the same or a little better generally than warfarin, but still, they're only going to stop about 2 out of 3 of every stroke. And so a person with AFib on a blood thinner is still at a fairly increased risk of stroke. And being on a blood thinner, they're at an increased risk of hemorrhage or a bleeding stroke. So one of the newer treatments for AFib, I'd say new, well, commonly at least new within the last 5 years or so, is a device like this. It's called a Watchman device or a left atrial appendage closure device. And so this is like a mini heart procedure. It's not open surgery, but this little device gets threaded into the heart and then deployed into the little, it's like the back room in the atria where clots usually form. And so this just seals over that little back pocket in the atria so that clots can no longer form. So this is as effective as the blood thinners, but of course you don't have the cost of blood thinners and you don't have the risk of bleeding. And so this is becoming more common, still usually is reserved for patients who have some reason they can't take a blood thinner or they have failed a blood thinner, that is, they've had strokes even while being on a blood thinner. But it is another option and one that is, I mean, for a lot of our patients, if we didn't have that and there's some reason they couldn't be on a blood thinner, we would really be up a creek. So it's great that we have that. All right. Well, maybe to pause for a moment, any questions about prevention and what we've covered thus far? Well, hearing none, I will proceed. So I said that perhaps 80% of strokes are preventable. That means 20%, even if you do everything right, they can still happen. And these are usually these are often in young patients. And for me are, the really devastating ones when it's the young mom with multiple kids. And anyway, so on the left here is Chris Letang. Very good NHL hockey player, had his stroke at age 26. Teddy Bruschi in the middle had his at, I think, 31. And Michael Johnson on the right, it was after his running career, but I think he was still in his 40s when he had a stroke. So as you might tell just by looking at these guys, they're clearly fit. They're not overweight. They probably don't have sleep apnea. They're unlikely to be smokers, and yet, still have strokes. So sometimes even our best attempts at prevention are not successful. So what do we do then? Well, increasingly, the American Stroke Association has tried to focus on educating the community on recognizing stroke symptoms. There are treatments now for acute stroke, but they're very time limited. And so the key is to identify or recognize strokes very quickly and get patients in the system in the hospital as quickly as possible. So the majority of Americans still don't recognize the principal symptoms of stroke and or don't know what to do when they do recognize those symptoms. So this is the short version of the American Stroke Association's stroke recognition tool. So FAST stands for facial drooping, often accompanied by drooling. Arm weakness, it can be the leg also, but as patients are often, sitting or lying, patients use their arms more than their legs when they're, say, sitting or lying down. So arm weakness generally gets recognized first. Speech difficulty, that can be either slurred speech, the inability to formulate words at all, the inability to understand words, and then the T stands for time to call 911. There is a slightly extended edition, which adds 2 more of the common stroke symptoms. So poor balance, strokes affecting the back part of the brain, sometimes cause just really severe vertigo, imbalance, staggering off towards one side. And then eyes, usually strokes that affect vision will either cause loss of vision off to one side or in one eye, or double vision. So if you can remember BFAST, balance, eyes, face, arm, speech, and then time to call 911, you'll be ahead of the majority of Americans and might just be able to save someone. So, and the import of this, again, as I alluded to a minute ago, is that the quicker we get to patients, the better they do. And so patients who get to the emergency department within 3 hours of when symptoms start do best. And patients who come in by ambulance do best. Now that second part, even if 2 patients get to the emergency department at the same time after stroke symptoms started, the one who walks through registration and triage, it's just going to take time to to figure out what's going on and sort of get things going. When a patient comes in by ambulance, the EMS crew will call in and tell us exactly what's happening. A code stroke will be activated. And basically the conveyor belt's already running before they hit the emergency department. And that can frequently save us 10 or 15 minutes. Speaking about saving time, I'm sorry that this is difficult to read, but what this is showing is different measures of outcome or different measures of how people do with a stroke as a marker of how soon after stroke symptoms started that they came to the hospital. And so basically they're less likely to be disabled the quicker they get there, less likely to die. That's what this bottom right one is. And so by many markers, and you see these lines are, I mean, every 5 minutes, every 2 minutes could make a difference in terms of the averages. So that's why we obsess about times in our stroke program and try to shave all the minutes off that we can. So if you've recognized a code stroke, it is best, or sorry, if you've recognized a stroke in yourself or someone else, it's best to call 911 unless you're like right next door to the hospital. Things will go much more quickly upon arriving in the emergency department if you come in by ambulance. And there are many studies now showing that that's the case. So just as another way of emphasizing the importance of time, for a researcher several years ago tried to quantify this. So if someone's having a large stroke, how much damage is being done per unit of time? And so for every minute that a blood vessel remains occluded with someone having a large stroke, that patient loses 2 million brain cells, 14 billion connections between brain cells, 7 miles of axons or the nerve fibers that make up the cells. And in that 1 minute, based on the number of cells they lose, their brain ages by 22 days. So for every hour, it ages by about 3.5 or 4 years. And so again, now often the patient gets here, does everything right, basically, gets to the hospital as quickly as possible. And there's nothing we can do based on where the stroke is or what type it is. So I don't intend this as a promise that we'll reverse this if you get to us quickly enough. Our best treatments are still not perfect. In fact, a long, long way from perfect. But you certainly give yourself the best odds by getting to the hospital as quickly as possible. This map is several years out of date now. The census data, it says in the bottom, is from 2010, but I think this map was from 2016 or so. So there are 30-some stroke centers within Tennessee. So the stroke center designation is developed by the American Stroke Association and the Joint Commission, which certifies various programs in hospitals. And so hospitals need to demonstrate a certain ability or aptitude in treating stroke and go through all kinds of evaluation to be designated as a stroke center. So there are 30-some now in the state of Tennessee. What this map shows, the people, and every purple dot is 250 people, the people who live within the darkest gray lived within 30 minutes drive of the nearest stroke center. We've talked about how important time is. So those are the people who are sort of best positioned to do well if they're having a stroke. The people within the next shade of gray live within 60 minutes, and the people within the lightest shade of gray lived more than 60, but less than 90 minutes from the nearest stroke center. And I'll tell you, if you overlaid by county the stroke death rates in Tennessee, you would see a big hole between Nashville and Knoxville, where people historically have not done as well having stroke. That would line up pretty well with the hole in this map. So as I was finishing training in 2017 and interviewing for the job here, I asked to meet with Paul Korth, the CEO, and showed him maps like this and said, I would love to come out here. We need to build a stroke center. There's this huge hole between Nashville and Knoxville where like 90% of Indians who don't have access to a stroke center live. And so it has been a lot of work, but we have in 2019, I think 2018, 2019, received our certification as a primary stroke center from the Joint Commission. And then it wasn't so long after that that the hospital in Crossville achieved the same primary stroke center designation. So we now have 2 stroke centers filling this sort of hole. And there are now, because there's now a stroke center in Columbia down here as well. I think there are now just perhaps a few thousand people or even fewer in Tennessee who don't live within 60 minutes drive of the nearest stroke center. So we're very happy to have, I think, done our part to meet this need in the region. So I talked about becoming a primary stroke center. It's just amazing, all the boxes that need to be checked to really prove that you're serious about trying to treat acute strokes well. But we've demonstrated that. We've actually been recertified and now have another recertification coming up. It's every 2 years. So coming up this winter. And so this is just one little piece of what becoming a stroke center has looked like for us. So this is the workflow when a patient comes into the emergency department with a suspected stroke. And this involves everyone from the emergency department nurses to the docs, to the CAT scan techs, to the lab people, to us as neurologists. And all of this is just ideally the first 45 minutes of someone's time with us in the emergency department with a suspected stroke. To say nothing of therapy and making sure they can swallow safely, and evaluation of depression, which is common after stroke, and all that sort of stuff. And so this is just to demonstrate one piece of the level of detail that has gone into try to improving our stroke care. So these last 2 bullet points are not specific to CRMC, but just based on multiple studies of primary stroke centers nationwide. A patient who gets to a primary stroke center, like we are, in the same time as a patient who goes to a hospital that's not a stroke center, the patient at the stroke center is twice as likely to be able to receive the emergency treatment that we can sometimes give people having an acute stroke. And I suspect, and no doubt because of that, patients treated at stroke centers have a significantly lower death rate from stroke than those treated at non-stroke centers. And I should add a brief addendum here to note that there is a difference between primary and comprehensive stroke centers. And more recently, 2 more levels have been added. The big difference is that comprehensive stroke center would be a place like Vanderbilt that can do every kind of interventional neurosurgery. We can do the great majority of things needed for most stroke patients, like well over 90% can get everything they need here. But sometimes we do send patients by helicopter to a place like Vanderbilt or St. Thomas or UT Knoxville for those rare things that we are unable to treat. And Tennessee actually has a stroke task force that was commissioned by the legislature to make recommendations to improve stroke care. I mentioned we're number 4 and not in a good way here. And so the stroke task force has made recommendations and they've been implemented by the legislature now. And so Tennessee state law, as of a few years ago, mandates that EMS crews take patients suspected of having a stroke to the nearest stroke capable hospital. So that would be sort of any level of stroke center. And so just to show that the legislature has recognized this as an issue as well. So just a few more minutes here. Still on the when prevention fails, you might see this bright white dot here on this CAT scan. So that's actually a clot within the artery. That patient is setting up to have a pretty massive stroke, which would leave them unable to talk, unable to move their right arm, leg, drooling out of the right side of their face. Their eyes would be deviated to one side. And so what can we do for that? Well, we can sometimes give patients a real strong clot buster drug called alteplase or TPA. This was demonstrated in 1995, so it's been around for a good long while now, to have some efficacy in breaking up the clots causing strokes and restore blood flow and lower the odds of disability after a stroke. slightly lower the odds of death as well. And then this bottom picture is a stent retriever device. So this is the procedure that is not done here. When we send a patient to another bigger facility, is often for this procedure. So there's a clot in a blood vessel, and they will, with a catheter, make a puncture in the groin, thread that catheter all the way up into the brain, and use that device to try to suck out the clot, ideally before the whole area of the stroke has been permanently affected. So that is the conclusion of the slide set. Are there questions about any of this?
Well, can you talk about the teamwork that you have with other, because the heart is also a big part of that, vascular. Talk about the other team effort that you have with other team members and other fields.
Sure. So, you know, the hip bone's connected to the leg bone and all that jazz. So, yeah, as I mentioned, atrial fibrillation, for instance, is a common cause of stroke. And so we identify a stroke. And usually that day we'll have one of our cardiac electrophysiologists, so the abnormal heart rhythm cardiologist, see the patient to start talking about what we ought to do to try to prevent the next one. We have some cardiologists who do that interventional procedure to close off the left atrial appendage in AFib. Because we don't know when we first see a patient if it's going to be an ischemic stroke or a bleed. If it's a bleed, we often have the neurosurgeons involved. We send a great deal of our patients to our rehab doctor over at the Blue Roof across the street. Of course, if there's diabetes is a contributing factor, we might have the endocrinologist see the patient. So we can, again, tee people up pretty well, usually, to lower their risk of a successive stroke as much as possible.
So you can get all that done here. Get it all taken care of here. If you have a stroke, come into the ED, you'll get taken care of. You know, somebody having a stroke, just bring them in. You'll get, you know, the signs. And we have the team effort here to take care of it, from heart to neurosurgery and medications. And what is a typical response time when someone comes in, they go to the CAT scan? Is it like 10 minutes? Is that what the?
That's about right. We try to have the CAT scan done and interpreted or read by the radiologist within 20 or 25 minutes.
Wow, that's impressive. So the time is matter. So
it is.
Yeah.
Time is brain, as they say.
Yep. So anybody else have any questions? One chat. Yes, a copy of this presentation will be available. I am recording this, so if you would like it, like a copy, just email me and I can get it to you. Any other questions? We can wrap this up a little early, but very informative. Yes,
Thanks for having me.
Absolutely. Thank you all for joining. And the next one will be in a few months. I don't remember what topic it'll be, but the email will go out and it'll inform you of what it is. So thank you so much.